Hi, my name is Dr. Nate Pennell. I'm a medical oncologist at the Cleveland Clinic Taussig Cancer Institute in Cleveland, Ohio. I run the Lung Cancer Medical Oncology program here. Now I want to talk to you a little bit about acquired resistance to ALK inhibitors in ALK-positive non-small cell lung cancer. We know that about 4% of patients with lung adenocarcinoma will have an ALK fusion gene that drives their cancer and is targetable with ALK inhibitors, and these drugs have been shown to really change the lives of patients with this type of lung cancer. Since 2011, we have been testing routinely for ALK gene fusions and treating them with a drug called Xalkori or crizotinib, which we know works in a majority of patients to put the cancer into somewhat of a remission and keep it under control for some period of time. Unfortunately, almost everyone will eventually develop what's called acquired resistance, and the cancer begins to get worse again despite initially responding to the Xalkori. And this can happen on average somewhere in the range of 10 months to a year after starting the drug. Although, of course, there are people who last longer than that, but sooner or later it does tend to become resistant. You have to make a change. The good news is we now have 3 FDA approved drugs to treat acquired resistance for ALK-positive lung cancer. The first one that was approved was called ceritinib or Zycadia, and this has been around since 2013. More recently, we've had 2 drugs approved in the last year and a half or so. The first one was called alectinib or Alcentia, and then the third one was called brigatinib or Alenbrug. All 3 of these are very effective in patients with acquired resistance to crizotinib. They work in probably between 50 to 70% of patients to put the cancer into a major remission, and they can last anywhere from 9 months to just over a year on average, with some people, of course, getting a much longer duration of control. The other thing that's really nice about all 3 of these drugs is that all of them penetrate into the brain much better than crizotinib does. And patients who have brain metastases tend to do much better on the newer drugs than they do on the older ones. So how do you know which one of these to pick? Well, there really isn't any head-to-head comparison of the 3 drugs, so they really don't know which of them is the most effective drug for patients who've been on Xalkori in the past. We know that the side effects, however, are somewhat different between the 3. So ceritinib or Zycadia tends to cause nausea and diarrhea, stomach upset at a much higher rate than the other 2. We know that alectinib actually has very few side effects. Sometimes can affect the liver, sometimes can cause some edema and fatigue. And brigatinib is very similar. It has relatively few side effects, although we do have to watch out because there's a small number of people who can have pulmonary toxicity with lung toxicity with cough and inflammation in the lungs, although not at a very high rate and probably very safe. So today, I think either brigatinib or alectinib would probably be my preferred drugs because of a more favorable toxicity profile compared to the Zycadia, but all 3 are very effective. What do you do if you're already on a second-generation ALK inhibitor and you then develop acquired resistance? Well, this is an area where there's a lot of research going on and there really isn't a perfect answer. We don't really know yet how well the second-generation inhibitors work after another second-generation inhibitor. We do have some data with a newer drug that's not yet approved, but maybe soon, called lorlatinib. And this was presented at the 2017 ASCO annual meeting that between 25 and 30% of people on other second-generation inhibitors do have a response to lorlatinib. So this could be very promising, but we still don't have all of the information yet to know what to do. So if you're on a second-generation inhibitor like ceritinib, alectinib, or brigatinib, and you have acquired progression or acquired resistance and progression, what you probably should do is either go on a clinical trial of a newer ALK inhibitor with a reasonable chance of working, or you should probably switch to chemotherapy if you haven't had that in the past. Chemotherapy can be quite effective in people with ALK-positive lung cancer. What's going to happen now that these drugs are starting to move into the first line? Well, that's probably a topic for another talk.